Started your 2 minutes time. There are total, I think, 5 or 6 rooms. Okay.
Next room, ma'am. Next, ma'am. Next, ma'am. Next.
Hello.
Next page, ma'am. Next room. Next one.
Started your 10 minutes time.
I am Dr. Muthulakshmi, one of the exam candidates today. Read the instruction, ready for the structured discussion.
Okay. So we are having this 6 cases now. Just tell me about each room or each case, what we are supposed to do.
So, room number 1 is symptomatic urinary tract infection in a 30-year-old primigravida, the Pseudomonas species. So, here we need to know the gestational age of the patient. And so, here anticipated risks will be recurrent urinary tract infection, pyelonephritis, and preterm labor and low birth weight. So, since the patient is discharged, so we need to contact their general practitioner, inform the report, and check the any drug allergies, and start her on amoxicillin 500 milligram TDS for 5 days, and she will be offered ultrasound KUB to check for any renal stones and any urinary tract anomalies. So in case of recurrent urinary tract infection, and she needs continuous antibiotic prophylaxis till delivery. And her further pregnancy care will be continued as regular. So room number 2, with increased NT of 4 mm, na primigravida with 11 weeks gestation, it's a singleton fetus. So here the anticipated complications will be increased nuchal translucency is associated with chromosomal disorders and the cardiac anomalies. So here the patient will be called and patient will be referred to the fetal medicine unit, and so she will be offered an should be counseled regarding pros and cons of definitive testing like chorionic villus sampling, amniocentesis, which tells the correct diagnosis, and also anticipated risk of 1 in 200 of abortion will be explained, and patient wishes will be respected. And about the screening test, it will be a screening test, so it will not tell about the confirmatory results, so which will be explained to the patient, and further action will be taken according to the patient opinion and the fetal medicine expert and a consultant obstetrician. And here we need to know additionally the age of the patient with respect to counseling, because increased age is associated with chromosomal disorders, age more than 35. So room number 3 is a patient with anomaly scan showing bilateral choroid plexus in a 29-year-old primigravida with 20 weeks of gestation, no other anomalies. So isolated bilateral choroid plexus cyst just needs follow-up. So patient has to be reassured and further follow-up as per the regular antenatal care. So no immediate action here will be recommended to the patient. So patient is hepatitis B surface antigen positive. She's 34-year-old, gravida 3, para 2, and routine screening she was found to have this screening. So here we need to know the gestational age of the patient, and here anticipated risks will be mother to child transmission during delivery. So the patient will be further referred to a gastroenterologist for further screening of hepatitis E antigen, viral load, and the surface antibodies. So if the viral load is more, she'll be started on antivirals if necessary to reduce the risk of transmission. And during delivery, neonatology team will be informed, and universal precautions will be followed during delivery. And post delivery, baby will be vaccinated, and hepatitis B immunoglobulin will be given within 12 hours of the birth, and she'll be screened for other sexually shared infections, and also her partner will be screened. If negative, partner will be offered a vaccination. Room number 5 shows the unilateral simple ovarian system 10 into 13 centimeter in a primigravida with 12 weeks of gestation. So here the anticipated risk will be, since it is a bigger cyst, may undergo torsion, hemorrhage, or a rupture. So additional information, we need age of the patient and any symptoms of torsion like fever, nausea, vomiting, and the CA-125 levels needs to be known. And here patient will be offered an elective laparoscopic cystectomy with the experts by discussing with the MDT team at 14 to 16 weeks of gestation. And patient will be reassured baby is doing fine. So this patient is RH isoimmunization with the gravida 2, para 1 living on 28 weeks of gestation. So here anti-C antibody with 8 international units. So we need to know here the anticipated risk is a hemolytic disease of the newborn. So here we need further information, age of the patient, and regarding the first pregnancy detail, we need to access the detail with their permission. So first pregnancy was complicated by abruption. So we need to know the further details in terms of gestational age and bleeding, and whether any blood transfusion was done at the time. And with regard to the baby, how was the baby doing? What was the baby's blood group, and mother's blood group and partner's blood group, and whether baby was given any exchange transfusion or any phototherapy post delivery, and what was the antibody level at that time during her first pregnancy, and what was the follow up done. And with respect to this pregnancy, she will be referred to a fetal medicine unit for serial monitoring of middle cerebral artery peak systolic velocity, and every 2 weekly um, antibodies levels will be checked. If the middle cerebral artery peak systolic velocity more than 1.5 multiples of median, then cardiocentesis and intrauterine transfusion will be considered depending on the gestational age and the fetal medicine and the neonatologist and the consultant input. And during delivery, so neonatology team will be involved, and for resuscitation of the baby, and further plan will be made after the birth of the baby.
Okay. Anything else you wanted to say in any of this room? Last 1 minute 20 seconds. Do you wish to say something or shall I end? No?
Can you can end, ma'am.
Okay. So I am pausing, okay?
Mm.
Well attempted. Okay. So anybody wants to comment on her performance? Anybody? Come up, dear, come up. No, no, no good thing, no bad thing, no nothing to improve. Okay. So Dr. Muthulakshmi, you have done a good job. Most of the most of the task, you have done identify the condition. Okay, identify the condition. You had anticipate what could be the problem with that condition, and then what are the measures you need to take, what additional information you wanted in each room. Okay, so it's almost clear pass. There are only few points which are there in my answer sheet, that we will be discussing. Overall, a good task by you, very nicely done. Okay, this small task also give you an insight, or this will make you prepare for a task like that, antibodies. That was a task which was asked in the last, I think in 2023 they had asked this task. Okay, so this kind of preparation will give you an overall preparation, or overall access towards the uh, at least a broader aspect of part 3 MRCOG. So good task, good job, huh? Only few points here and there. So coming to the answer key of this case, first, do not read out, just identify what is the situation. The next thing is, as you rightly said, what are the anticipated risk associated with that condition or that situation? And thirdly, what all measures you are going to take to minimize the complications which is anticipated, and which streams you would like to involve, whether you would like to involve the consultant or any other specialist you would like to involve. Like in room number 1, as you mentioned that she will be the GP will be providing her regarding the antibiotic, so something like that. So this is what the answer is. So here in this case, my situation and background is primary gravida with urinary tract infection with pseudomonas specific species positive. So she is at risk of, so the anticipated risk as rightly mentioned by you is preterm labor, even PPRM. They are at risk of PPRM leading to prematurity. It is not low birth weight, it will be prematurity. If untreated, can also lead to pyelonephritis, chronic cystitis, or chronic recurrent urinary tract infection, whatever you wanted to say. So the treatment of choice in this case, as she is pregnant, this gentamicin and tetracycline is not safe during antenatal care. Okay, so yes, very nicely you asked here what is her gestational age, which was not mentioned here. So the modality of treatment will be tablet amoxicillin or capsule amoxicillin, 500 milligram BD or TDS depending upon the doses, so mostly TDS, which needs to be arranged at GP surgery. Since the patient is not discharged here, the patient was seen in the hospital. Okay, she was being seen in the hospital. She was not admitted, so she needs to. This needs to be communicated to the GP surgery for further community-based care. Okay, so if she get relieved, she can continue her follow as it is. If she is into community based care, so she will continue her community based care. Meanwhile, we will also assess her ultrasonography, KUB for kidney status and any abnormality in renal stones. Okay, follow up. Important point here is, if no response to the antibiotics, symptoms aggravated, then she needs to come back. Okay, she needs to follow. Mm. So that is one additional point what I had mentioned, because we assume that it will get treated, but we need to keep both the channels open. If treated, continue her care in the primary health care. If not, then she needs to follow up for further management. So very nicely done this task also. Now, this task, I am having little bit of correction. You rightly mentioned that increased NT is associated with chromosomal or cardiac abnormalities. Yes, here only they had given NT just to see what next you are going to do. Now, the next thing will be you have to calculate her combined screening. Hmm? Only on the basis of NT, you cannot assume that it is chromosomal abnormalities. If there will be raised from combined marker or abnormal combined, sorry, not traced, abnormal combined screening of this case, which will be calculated by including age of the patient, then only she will be at risk of chromosomal abnormalities, and in that case the patient will be referred to the fetal-maternal unit, where there will be discussion regarding the sequential or contingent screening, they say. So the sequential or contingent screening will be depending upon the risk, whether she is high risk, intermediate risk, or low risk. They will either offer her non-invasive prenatal testing or invasive prenatal testing by discussing pros and cons of both the options. Um, Non-invasive prenatal testing is not a confirmatory test. Even if it turns out positive, in that case, she will be guided regarding invasive testing. And in this invasive testing, the chances of having miscarriage will be discussed, chances of having infection will be discussed. So these all will be discussed in FMU, if the combined screen is abnormal. But if the combined screen is normal and NT is high, then in that case, so this point you have not discussed, Dr. Muthulakshmi. In that case, the patient will be seen in fetal maternal unit still, because the patient is at risk of cardiac anomalies. So the detailed anomaly scan will be from the from where fetal maternal unit. Okay, so this way you are going to mention both the options, that combined screen is very important here, and this is something like that contingent or what we can say sequential screening. Okay, so this is very important. Now, your next case was choroid plexus cyst on anomaly scan. Here, one important point is, yes, you mentioned that no other single marker. This is a single marker, but here you would like to know her double marker or combined screen result. If combined screen result is normal and single marker, then yes, we can very easily reassure this patient. Most of the time, this choroid plexus cyst disappear on further follow-up scan. She will be followed up with ultrasonography. Okay, she will be followed. She will have a follow-up ultrasonography. Uh, if other soft markers are there, now this is a situation what they had given, but by any chance if there is an abnormal combined screen or other soft markers, then in that case fetal-maternal unit reference will be done for further testing. Here they had not mentioned, so we are assuming that it is a low risk patient with normal combined screen, so needs reassurance is the treatment. But you just need to tell one line, so if at all there will be any other soft marker present uh, or abnormal combined screen, then in that case patient will be seen in fetal maternal unit for further follow-up. Okay, so this is correct. Actually, I do not have anything but additional point what I wanted to mention. This has been mentioned missed, this has been done very nicely by you. Okay, So here the patient is HbSAg antigen positive. So baby is at risk of vertical transmission. So involving gastroenterologist, gum physician, virologist, consultant, neonatologist is very important. So basically it is a MDT. Now we need to assess patients overall, whether the patient is symptomatic or not. Liver function test, ultrasonography of abdomen or liver, HBE antigen, HB, viral load, and depending upon that, the gastroenterologist will be involved for need of antiviral medications. Okay, so the safer antiviral medications can be considered depending upon the baseline investigation what patient will be having. Very nicely, you mentioned that we need to rule out any other sexually transmitted infection like HIV, HCV. If HIV done at booking, we may have to repeat after 3 to 6 months. Okay, so that is very important. Neonatal immunization and IgG administration post delivery. Screen her and her partner with along with other kids. If she's having other kids also, she's gravida 3 para 2 living 2. Okay, so we are assuming that she's having another 2 kids, so those kids also needs to be screened. Discuss immunization of partner, safe sex and gum clinic. Okay, so mostly you had done a very wonderful job in this task, in this room. Uh, Now this is also done very nicely. So it is a simple cyst which has mentioned. So this case is at risk of torsion, hemorrhage or rupture. So that is a acute abdomen. So she may have a risk of acute abdomen. So we need to inform this patient regarding the acute emergency situation, when and where she needs to present herself if there will be any acute pain, any nausea, vomiting. She needs to be presented with 24-hour contact details. Otherwise, we need to offer a cystectomy at 14 to 18 weeks of gestation. The keyhole approach. Okay, so most of the times, if it is 14 to 18 weeks, we can very easily go ahead with the keyhole approach. But if expertise are not available, then laparotomy is also needs to be discussed. Patient will be consented for the same. Pros and cons will be discussed. Okay, so that consent is important. Pros and cons of the procedure is important, which needs to be discussed. Anesthetist review, discuss with her care and document with information leaflet. We need to give her information leaflet. Any associated symptoms, any type of cyst. Okay, since simple cyst, the significance of tumor marker is variable in pregnancy, and since it's a simple cyst, we do not need any further investigation. But if there are any concerns regarding the type of cyst, then in that case MRI will be the choice of investigation. In this case, MRI will not play any role because they had mentioned unilateral simple cyst. So no role of CA125, no role of MRI. But if there are any concerning picture, any concerning factor which will be seen, in that case MRI is important. And CA125 in pregnancy, questionable. Okay, because CA125 is actually many a times seen raised in pregnancy. So CA125 variable significance during pregnancy. We need to give this patient information when to follow up in case of emergency with 24-hour contact details, elective procedure at 14 to 18 weeks. Okay, so very nicely done this was also. And lastly, this is rhesus isoimmunization with small c antibodies. Explain implication of this condition on fetus. That is, the patient is baby is at risk of hemolytic jaundice, hemolytic anemia, including fetal anemia or sometimes hydrops. So serial measurement of anti-C antibodies is very important. Since the anti-C antibodies are 8 international unit, the higher level is 7.5. Yes, it is 7.5. Okay, when we are going to refer it to the fetal medicine expert. Do you have any idea? Nobody's answering.
Sure.
What is the highest level when you need to refer this patient for a fetal medicine expert opinion?
7.
7.5 or 7?
7.5.
Yeah, I think it is 7.5. Okay.
Okay, I'll
So,
check
but
it.
yeah, broadly, we need to refer this case for a fetal medicine expert for monitoring of middle cerebral artery, PSV, as you rightly mentioned. Okay. Any previous history of blood transfusion, and what was the baby? Okay, baby's outcome, previous baby's outcome, how was it? Okay. Details of previous pregnancy is very important here. She will be under joint care. Here, the care will be in consultant, hemat, neonatologist, and FMU. Yes. Now, we had considered the risk associated with the fetus. Okay. But what if the patient is at risk of PPH? If it is at the patient is at risk of PPH because she had previous abruption, yes or no? So again, there is a risk of abruption where she might need blood, and her blood is having red cell antibodies. So she needs to be booked at tertiary center where risk of PPH, since she is at risk of PPH, where cell salvage facility will be available. Her blood and blood products will be kept ready. Weekly cross match will be available. Active management of third stage of labor will be offered to this case and minimize whenever there will be any blood loss, excessive blood loss. Efforts will be made to minimize blood loss. Okay. So that is an additional point because of abruption. Yes, we are going to assess this anti-C antibodies, but again, that is additional point because she is at risk of PPH because of abruption. Yes. So that point you missed out. Overall, it was a nice presentation. So information gathering, able to interpret information from investigation appropriately, which you have done, is able to initiate additional investigations to help make a diagnosis, which we were able to do, has an understanding of additional information that may be required, helped at the diagnosis and plan care. Communication with patient and families, give information sensitively in manageable amounts regarding the investigation in pregnancy and management. Communicate the implication of abnormal result for the patient and the fetus, including future pregnancy. Clear logical action plan. Okay. Communication with colleagues, so ability to prioritize cases appropriately, refer them for timely investigation. In first case, it was GP. Most of the cases, it was FMU. Okay. HEMAT in this anti-C antibodies. So it is very important of the time, especially in relation to prenatal diagnosis. Describe differential diagnosis and formulate an appropriate management plan. Refer appropriately to the other specialties like fetal medicine and hematology. Patient safety has an understanding of their limits of the clinical abilities and demonstration at an understanding of when to refer patients to senior colleague and other disciplines. Initiate steps to mitigate risk, articulates clearly the risk of action. Okay. So knowledge basically is an overall knowledge. We will whatever knowledge is associated with this task will be from the day-to-day activities, nice RCOG guidelines, okay, or any talk. So very well done. Anybody is having any question? Anybody? No?
No, ma'am.
Thank you.